டெஸ்ட் பண்ணுறாங்க. ஸ்டார்ட் பண்ணலாம். ஹலோ, கேட்குதுங்களா? எப்போ ஸ்டார்ட் பண்ணலாம் மட்டும் சொல்லுங்கள். ஓகே, நீங்கள் வந்தோடனே சொல்லுங்கள். அந்த டைம் ஸ்டார்ட். ஓகே, சரி, தேங்க்யூ. Okay, very good afternoon, students. So today we are going to discuss about the recent INICET surgery mock test conducted by ADrPLEXUS, and we are going to have a test and discussion of the same. So we are going to discuss about 60 questions. All these were taken from high yield areas that are required for INICET examination. And we will go through all the questions as well as the answers, and as well the related high yield areas to be covered related to the topics that have been asked in the question paper, right? So let's start with the first question. So the first question is about skin graft. Okay, so the true statement regarding the skin graft is full thickness graft has more secondary contraction, and primary graft contracture is due to the elastin. Full thickness graft take is better than split thickness graft, and split thickness graft preserves sensation. So to understand this question and to answer this question, we have to know about the basics about the skin graft. So the skin graft is nothing but, what do you mean by a graft? Graft is nothing but a non-vascularized skin. Non-vascularized skin graft. The graft in transplant is different from the skin graft. Okay, the transplant grafts are vascularized one. So the non-vascularized skin is called the skin graft. They are commonly used in areas to cover the skin. More commonly, where it will be used most commonly in burns and in post-traumatic raw areas or the post-debridement areas in cases of diabetic foods. So there are two types of skin graft. One is going to be the split thickness skin graft, and another one is going to be the, so one is split thickness skin graft Another one is called the full thickness skin graft. The split thickness skin graft is otherwise called as Thiersch graft. And the full thickness graft is otherwise called as Pulfi's graft. The basic difference between a split thickness and the full thickness graft is, in the split thickness graft, epidermis and only a part of dermis has been grafted. A thin dermis will be grafted. Whereas in a full thickness skin graft, both epidermis and as well the dermis will be taken, will be harvested. So this is the picture that shows the epidermis as well as the dermis. Only in the dermis we will have the skin appendages. Skin appendages like sweat glands, sebaceous glands, sweat, sebaceous, as well as hair follicles. And the reason that this beneath the area that is beneath the dermis is called the hypodermis, or otherwise called the subcutaneous tissue. So where will you use split thickness skin graft? Where will you use full thickness skin graft? And how do you harvest the skin graft? And what is the process of grafting? And what are the advantages as well as the disadvantages? We will discuss further. So this is the common example of a indication for a skin grafting. Here, this is a diabetic wound which have granulated. So where you can granulate it very well. Okay. So where you can harvest the skin graft? I mean, what are the sites of harvesting skin graft? So the commonly split thickness skin graft are routinely harvested from thighs as well as abdomen. Whereas the full thickness skin graft are harvested from areas where there is skin laxity, like eyelids, supraclavicular areas, groin, as well as the elbow crease. All the creases where the skin will be lax. So following the harvest of a split thickness skin graft, that is the donation area need not be closed. I mean, that does not require any closure because we are only harvesting a part of the dermis. The remaining dermis will have the regenerating epidermal cells that causes the closure of the area. So the harvested area heals by 21 days in case of split thickness skin graft. Split thickness skin graft, I'm writing it as STSG. Whereas full thickness skin graft, these areas require primary closure. Primary closure. So you cannot harvest large amount of full thickness skin graft, or else the donor area cannot be closed primarily. Whereas a split thickness skin graft can be harvested for a larger areas. This is one of the advantages. Then moving on to the place of grafting. So that is called the graft bed. The graft bed should be well vascularized and it should be free of infection. Only then the graft take will be good. Right? What do you mean by graft take? You harvest the skin graft with the help of what is the instrument that is used for harvesting the skin graft? So you use a Humbee's knife, and the blade that is used is called the Downey's blade. You make a staggering movement, to and fro motion. The tangential skin graft will be harvested with the help of this Humbee's knife. Sorry. So the graft take usually occurs in 3 phases. Number 1 phase, so it's called as a plasma imbibition. Once you place the graft over the granulation tissue or the wound, there occurs plasma imbibition. Initially, the graft takes nutrients from the exudate that is happening between the, so this is the graft, this is the wound bed. So between these, the graft gets nutrients from the wound bed. So the nutrients for the graft will be taken from the plasma exudate. This is called a stage of plasma imbibition. It usually happens up to 24 to 72 hours. Then inosculatory phase. What do you mean by inosculatory phase? So this is the granulation tissue. Okay. This will be the graft. So the graft will develop the angiogenesis, that is the neoangiogenesis. Whereas from the granulation tissue, the blood vessels happen. Blood vessels grow towards the graft. This is called inosculatory phase or the angiogenic phase. So the graft vessels as well as the recipient vessels will get aligned to provide vascularity to the graft. Okay, this is, and finally remodeling phase. This phase usually occurs for 5 to 7 days. Remodeling phase is formation of the fibroblastic activity, thereby causing wound healing with contraction. This is called the remodeling phase. So what are the contraindications for skin grafting? So whenever there is any infection, particularly beta hemolytic streptococci infection is a contraindication for skin graft. That's why before placing a skin graft, you should do a culture sensitivity from the donor area and you should rule out microorganism growth. Particularly beta hemolytic streptococcus. Why? Because it has a lytic action. So you will be placing the graft and you will be looking the graft after 3 days. That is called the first look. So you look the graft after opening the dressing, the graft must have been disappeared because of the beta hemolytic streptococci. That's why you have to rule out beta hemolytic streptococci growth before undertaking any grafting. Now moving on to the advantages as well as disadvantages of the grafting. So split thickness. So the advantages of the split thickness are, as we already discussed, it can cover large area. And number 2, you can harvest from large area. Number 3, the donor site heals in 21 days. Since it heals from 21 days, it can be reharvested from the same site. Reharvested from the same site after 3 weeks. Since split thickness graft has only a minimal part of the dermis, the graft take will be very much good. So for example, if you own a 1 liter car, the mileage will be very more. Okay, it won't consume more of fuel, whereas a 2 liter petrol engine will consume more amount of fuel. Likewise, the split thickness graft will consume less amount of fuel. So that means less amount of vascularity is required for the graft to survive. So the take will be good. Now moving on to the disadvantages. The disadvantages is the split thickness skin graft. They have a poor cosmetic outcome. And the secondary contracture is more. Secondary graft contracture is more. So what do you mean by secondary graft contracture? So whenever you harvest a graft, initially for example, you are harvesting a 4 by cross 4 centimeter square graft. Immediately after harvesting, the size will become 3.5 cross 3.5 centimeter. Why? That is called primary graft contraction. So this primary graft contraction is due to the elastin that is present in the dermis. So in split thickness skin graft, do we take more of dermis? No. That means the elastin content in the split thickness skin graft is very less. Thereby primary graft contraction is very low. Moving on to the full thickness skin graft, the primary graft contraction will be very high because of the more amount of elastin content that is present with the dermis that has been harvested along with the flap. The secondary graft contraction is due to myofibroblast activity. That is the phase of remodeling. The phase of remodeling has increased amount of myofibroblastic activity, thereby causing wound healing as well as contraction. This myofibroblastic activity will have very pronounced effect on the split thickness skin graft than the full thickness skin graft, thereby causing more amount of secondary graft contraction, leading on to poor cosmetic outcome. And the final disadvantage is it cannot preserve sensation. Whereas the full thickness skin graft contains more amount of dermis, so it contains sweat glands, sebaceous glands, as well as the nerves, as well as the vessels, as well as hair follicles. So it will have a better color match, better cosmetic outcome, as well as it preserves the sensation. It can sweat, it can develop hair also. Those are the advantages of full thickness, which will be absent in split thickness because they don't have the dermis. Moving on to the full thickness. Similarly, the advantages of, as I mentioned, it preserves sensation, as well as it can have a maintain temperature. It can grow hairs. Number 2, better color match will happen. So in fact, if you are planning for any facial grafts, you have to use the full thickness skin graft, thereby having a good cosmetic outcome. The disadvantages are, number 1, primary graft contraction is more. As I discussed earlier, it is due to the due to the elastin content, and cover only small area, and the donor area have to be closed. So with this idea, can we move on to the question to answer the full thickness skin graft has more secondary contraction. The secondary graft contraction is due to the myofibroblastic activity that is seen with split thickness skin graft. So it's a false statement. Primary graft contraction is due to the elastin. This is a true statement. Full thickness skin graft take is better than the split thickness skin graft. Actually, full thickness skin graft take is relatively poor than the split thickness. And split thickness skin graft preserves sensation? No, only full thickness skin graft preserves sensation. So I think I have made it clear about the skin graft, and I have also discussed about the high yield points related to the skin graft. So with this, shall we move on to the next question? Right. So this question is based on the knowledge regarding the flaps. So previously we discussed about the graft, and this is about the flaps. Mathis and Nahai classification is used in which of the following flaps? So for this, we need to know about what is a flap. Flap is a vascularized tissue. That is a vascularized tissue transfer. So there are several kinds of classification for flap that is available. So the common classification for flaps, Number one, it's based on the circulation. Based on the circulation, it can be a random pattern flap or an axial pattern. I'm not going into the details of all these flaps. I'm just going to make it very easy for you to understand regarding the flaps. So what is a random pattern flap? So the flap is based on any unnamed artery or unnamed vessel. So the flap based on unnamed vessel. When we know that this vessel is going to supply this area of skin and that vessel has a name, that is called an axial pattern flap. So when we know about the anatomical region or the territory that the vessel is going to supply the skin, the chances of necrosis are very rare. Chances of flap necrosis is rare. It is more common with random. That is, flap necrosis is more common because we might harvest a part of the skin island that is not supplied by this vessel. So the chances of flap going for necrosis is very high with random pattern flap. The next classification is based on composition. Like, so whether it is based, it includes fascia as well as the skin, fascia cutaneous. It includes a muscle with skin, myocutaneous. It involves the bone along with the skin, that is called osteocutaneous. The common example for fascia cutaneous flap is a radial forearm free flap or a anterolateral. ALT is anterolateral thigh flap. The common example for myocutaneous is LD flap, that is latissimus dorsi myocutaneous flap, and pectoralis major myocutaneous flap. The common example for osteocutaneous is it's a fibular flap. You harvest a part of the fibular bone along with the overlying skin that is commonly used for reconstruction of mandibulectomy defects. Then based on the area it covers, so it can be local, regional, as well as distant. Okay, local means the flap itself forms a side of the defect. Suppose this is the scalp. Okay, there is a lesion and you have resected it. So in order to close these, you can make a rotation flap. Okay, you can make a rotation flap. So after excising this, you can bring the skin to close this defect. This is called a rotation flap. So this area will be approximated by the skin that has been brought from this area to this area by making an arc of rotation here. Okay, so here the flap itself forms a side of the defect. That is, the flap is very adjacent to the defect. That is local flap. Regional flap is quite away from the defect. Like, for example, you are harvesting a pectoralis major myocutaneous flap from chest, and it will be tunneled towards the neck to reach the oral cavity. So this is called a regional flap, or you use a latissimus dorsi flap from the back to cover the breast. LD flap for breast reconstruction from the back towards the chest. These are called regional flap. And distant flap are nothing but a microvascular free flap. So these are examples for pedicled flap also. They have a vascular supply that is present from the site of origin of the vessel. Whereas the microvascular free flap, they will be their vascularity will be transected from the origin of the donor site, and they will be placed in the recipient area, and they will undergo the vascular anastomosis to provide vascularity to the graft. So for example, radial forearm free flap. So this is the hand. Here we are harvesting the skin island based on the vessel. You are removing the skin island along with the vessel. You are placing it in the, this is the tongue, commonly used for tongue reconstruction. Hemiglossectomy has been done. So what you will do, you will place the radial forearm free flap here along with the two vessels. These two vessels will be anastomosed to the recipient site vessel. So the commonly used recipient site vessel will be the facial artery and vein. So this is based on a radial artery and a cephalic vein. The radial artery will be anastomosed to the facial artery, and the cephalic vein will be anastomosed to the facial vein. This is the way the free flap or the microvascular free flap works. So based on this classification, these are the common classification for flaps. Now moving on to the Mathis and Nahai type of classification. So this is the Mathis and Nahai type of classification, the second image. So this is the image that is taken up from the recent edition of Bailey. So the Mathis-Nahai classification is for the myocutaneous or a muscular flaps. Any flap based on the muscle, we use Mathis-Nahai classification. So the type 1 muscle is have a single dominant pedicle. So the common example is a tensor fascia lata muscle that is present on the lateral aspect of the proximal thigh. This tensor fascia lata is commonly used to cover the groin reconstruction. Okay, like for a pineal cancer where you will remove excess of skin, in such cases for primary closure you can place a tensor fascia lata flap. And the type 2 is, it contains a dominant pedicle as well as a minor pedicle. The most important difference is the flap cannot survive with minor pedicle alone. The flap cannot survive with minor pedicle alone. So definitely this dominant pedicle should be preserved. Whereas type 5, it has a dominant pedicle as well as multiple minor pedicles. The only difference between type 2 and type 5 is the muscle can survive, or the flap can survive even without dominant pedicle. Okay, so this is the type 1 and type 5 difference. Type 3 has 2 dominant pedicles. The common example is gluteus maximus. For type 5 graft, the common example is latissimus dorsi as well as pectoralis major. And type 4 is multiple segmental pedicles. This is type 4. So, and there is another classification for faciocutaneous flaps that is called Cormack and Lamberti classification. Just know this classification. I think it's way beyond your scope of knowledge. Generally, for plastic surgeries, these will be asked, but you should be very aware of all these classifications, which are very much high yield for the examinations. Now, let's go and answer the question. Matthijs and Nahai classification is used in which of the following flaps? The answer is obvious, that is myocutaneous flap. Now, moving on to the third question. Like, which of the following is a human dermal substitute? Okay, so what is this dermal substitute? Okay, so this is the area of interest for majority of the AIMS examination. Dermal substitute. That means you should identify why there is a dermal substitute. So the dermis is the most important skin part that starts regenerating. So that's why when you do a split thickness skin graft, the donor area can heal by itself because of the regenerating cells from the dermis. So what are the cells that are present in the dermis? They are called fibroblasts. What are the cells that are present in the epidermis? They are called keratinocytes. So with the help of these cells, the dermal substitutes have been engineered. Okay. So the dermis is very much essential for forming a scaffold for any other healing to take place. Okay. So with this, we will answer this question. So the dermal substitutes are commonly classified into cellular as well as acellular. Cellular dermal substitutes are commonly rejected by the body immune system. So hence cellular dermal substitutes are not used nowadays. Only acellular dermal substitutes are being bioengineered as well as produced and sold in the markets. So the common example for the acellular dermal matrix is the alloderm. It is purely human derived dermal substitute. So you can apply alloderm over any wound areas, and this alloderm acts as a scaffold for wound healing. It doesn't have the keratinocytes. I mean, it doesn't have the keratinocytes or the fibroblasts, but it has all the extracellular matrix and the growth factors that are required for the wound healing. So you can place a alloderm and over which an skin graft can be placed that can help in closing any deep burn wound also. So this is about alloderm. So the answer is alloderm. Let's discuss about the other options. What do you mean by integra? Integra is another acellular dermal matrix, but it is not humanized. It is from a bovine collagen and sheep chondroitin. So these are nothing but glycosaminoglycans that forms a scaffold for the wound healing. Right. So with the integra application, integra is mainly used to cover large burn areas. Okay. So you place integra over the burn areas. After 2 weeks, the dermis would have formed, and after that you can place the skin graft. The most important advantage of Integra is nothing but it is a bilayered one. So the bottom layer will have this forms the bottom layer, and over which you will have a silicone sheet. This will prevent the wound from exudating. It will prevent the wound from leaving all the nutrients. So after 2 weeks, this silicone sheet will detach from the bottom layer, and over which you can place a split thickness skin graft, and the wound will heal fantastically. So this is the application of Integra. It is commonly used in partial thickness burns, particularly deep partial thickness burns, to act as a scaffold. And another one is Epicel. Epicel is pure epidermal substitute. Its current use is investigational. Okay. Because we are not going to use epidermal substitutes. There are very less indication for the epidermal substitutes to be used. And finally, ADrPLEXUS. ADrPLEXUS is a totally bioengineered skin. Bioengineered entire skin substitute. Okay. So it contains keratinocytes as well as fibroblasts. Keratinocytes forming the epidermis as well as the fibroblasts forming the dermal scaffold to form an artificial skin. So it has been recommended by US FDA in diabetic wound closure instead of skin graft. Diabetic wounds as well as the venous ulcer. ADrPLEXUS is a US FDA recommended artificial skin that has been used for diabetic closure of the diabetic wound as well as the venous ulcer. But the disadvantage is its cost is very high, and the second thing is it can cover only small areas. And it takes longer time to create the ADrPLEXUS. So these are the limitations of ADrPLEXUS. I know this dermal substitute question is a bit theory, but I just wanted you to make you people aware of all these newer terms that can be asked in your examinations. Right. So now let's moving on to the next question. That is, which is false regarding the idiopathic intracranial hypertension. Right. So for this, you should know about the CSF pathology, CSF production, and what are the causes for raised intracranial pressure, what are the methods to treat the raised intracranial pressure, as well as the other types of intracranial hypertension. So this idiopathic intracranial hypertension is otherwise called as benign intracranial hypertension, or it is also called as pseudotumor cerebri. So let's discuss about this idiopathic intracranial hypertension first. Later, we will discuss about the other causes of CSF pathologies, right? So this idiopathic intracranial hypertension is otherwise called as benign intracranial hypertension or pseudotumor cerebri. So to explain this, the lumbar pressure will be high. The lumbar pressure will be high, but you don't know the reason. That's why it is called idiopathic, or there is no mass. There is no mass lesion in the brain. That's why it is called pseudotumor cerebri. Only the pressure will be high, and we could not make out any reason for the rise in the intracranial pressure. Okay, that is called idiopathic intracranial hypertension. It is a peculiar condition which is very commonly seen in young obese females. Okay, because of this young obese females, they have an increased intra-abdominal pressure. This in somehow prevents the intravenous drainage from the brain, thereby causing increased ICT. So it's basically due to a unknown cause that is causing this intracranial hypertension. The aim is to relieve the intracranial hypertension by doing a lumboperitoneal shunt. So if this intracranial hypertension is not being treated, so they commonly present with headache, visual disturbances, and more commonly blindness can also happen. Visual disturbances is due to the cranial nerve compression because of the increased intracranial tension. And finally, blindness can happen when there is papilledema. I can even quote you a real case scenario. Recently, like not recently, one year back, a patient is a young obese female, 33 female, mother of 2 children, presented to me with duodenal mass, for which Whipple's was planned. This patient had a lumboperitoneal shunt. She gives history that has been done 1 month back. The patient gives history of severe headache, for which they consulted the neurosurgery people, and they have identified her to have a idiopathic intracranial hypertension. So they have done the imaging, and in MRI there was evidence of papilledema too. Okay, they did a lumboperitoneal shunt. Lumboperitoneal shunt is nothing but a shunt that is placed between the lumbar canal towards the peritoneum. So whenever the CSF pressure rises, it will drain into the peritoneum. So this is called a lumboperitoneal shunt. Why I am concerned with this lumboperitoneal shunt is the lumboperitoneal shunt came. So this is the abdomen, and this is the vertebra. The lumboperitoneal shunt was kept like this from the back in the subcutaneous tunnel, and make a incision, and it is placed inside the peritoneum. Why I am concerned is I am going to make an incision here for this patient. What if the subcutaneous tunneled catheter will be cut while during the incision? So while making the incision, I have to make a proper cut, and proper imaging investigation has been done. And another concern with the lumboperitoneal shunt for my case is because I am going to undergo a major abdominal surgery. So what if there is any leak that happens after the surgery, any bowel leak or anastomotic leak? Whenever there is any leak, there will be intra-abdominal sepsis. That sepsis will be taken along the lumboperitoneal shunt towards the meninges. It can even cause a meningitis. So hopefully, but that patient recovered without any infection or any anastomotic leak. That's so whenever you place any shunt in the peritoneum, the future surgeon should be aware of all the complications associated with the shunt. The surgeon should discuss with the neurosurgeon for the prompt management as well as antibiotic prophylaxis, whether to displace the catheter in the infracolic compartment or not. All these should be discussed with the neurosurgeon, right? So this is the picture that shows the CSF production as well as drainage. So this is the ventricular system. Okay. So where the CSF will be produced? The CSF will be produced from the choroid plexus. The choroid plexus are commonly present in the lateral ventricle. From the lateral ventricle, it enters into the third ventricle through the foramen of Monro. From the third ventricle, it enters the fourth ventricle. Okay, fourth ventricle through the cerebral aqueduct or aqueduct of Sylvius. From the fourth ventricle, So this is the fourth ventricle. It enters into the spinal canal through a lateral foramen of Luschka, or Luschka L for L, and a medial foramen of Magendie. Then it enters into the CSF column, and finally it gets absorbed in the superior sagittal sinus. So it is produced inside the ventricles, then makes its way through all the CSF pathways, and finally it gets drains into the superior sagittal sinus. Whenever there is increased production, like in a case of a choroid plexus, that is, these are the causes of hydrocephalus or a raised intracranial pressure. Whenever there is increased production, that can cause hydrocephalus. Number one, any obstruction. Suppose there is a mass that is present here that is compressing the aqueduct of Sylvius, thereby causing enlargement of the third ventricle as well as the lateral ventricle. That is the obstructing hydrocephalus. And finally, defect in absorption. That means the absorption happens at the level of superior sagittal sinus. The common defect in absorption, the common causes are going to be any infections, any head trauma, or any prior hemorrhage, subarachnoid hemorrhage. All these can have an impact on the absorption of the CSF. All these can cause a hydrocephalus. So whenever there is a clear-cut obstructing cause, that is called an obstructive hydrocephalus, and there is a defect in the absorption, that is called a communicating hydrocephalus. The only important difference between communicating versus obstructing hydrocephalus is that LP is lumbar puncture is contraindicated. Here, lumbar puncture is therapeutic. Why lumbar puncture is contraindicated in obstructing hydrocephalus? Suppose this is the mass that is causing. If you do a lumbar puncture here to drain the CSF, what will happen? Because of this pressure, it will cause cerebral herniation. So to prevent the cerebral herniation and the rapid deterioration of the patient, in obstructing hydrocephalus, you should not do a lumbar puncture. Whereas in a communicating hydrocephalus, lumbar puncture is therapeutic. Like in a idiopathic intracranial hypertension, it is an example of a communicating hydrocephalus where lumboperitoneal shunt is effective. So what to do in a case of an obstructing hydrocephalus? So ideally, it should be identified by imaging systems to identify what is the cause. And based on the level of obstruction, the following treatment options are there. The most important being, our aim is to reduce the intracranial pressure. So the intracranial pressure here in the situation is either due to increased CSF or a mass lesion. Both should be treated. So this is treated with the help of an external ventricular drain. External ventricular drain is commonly done by inserting a drain by making a specific burr hole in the brain reaching in the lateral ventricle. So if you look at this, this is the external ventricular drain with the tube that is placed in the lateral ventricle. There will be a valve here. So whenever there is increased CSF volume, it will be drained downwards. So this external ventricular drain insertion is done at the level of a Kocher's point as described in the latest edition of Bailey. What do you mean by a Kocher's point? So the Kocher's point is nothing but 1 centimeter anterior to coronal suture and 3 centimeter lateral to midline. You make a perpendicular entry towards medial canthus, you will reach the lateral ventricle or the lateral horn of the ventricle, thereby facilitating the CSF drainage. The distal end can be placed in the atrium, that is called a ventriculo-atrial shunt. It can be placed in the pleural cavity, that is called a ventriculo-pleural shunt, or it can be placed in the peritoneal cavity, that is called a ventriculo-peritoneal shunt. Okay. So the common complications of VP shunt, that is a ventricular-peritoneal shunt or a ventricular-atrial shunt or a ventricular-pleural shunt. Number one, shunt infection. Number two, shunt malfunction or shunt obstruction. Due to infection, any debris can happen that can go in for an obstruction. Whenever there is shunt infection or obstruction, the shunt should be replaced with another shunt placement. Okay. So with this, we have discussed about the intracranial hypertension as well as the CSF pathologies, and most commonly hydrocephalus. We have discussed about the high yield aspects of cochlear spine. We have discussed about the communicating hydrocephalus as well as the obstructing hydrocephalus. Another important MCQ that can be asked is, what is the normal CSF volume? Normal CSF volume is 150 ml. How do you maintain the cerebral perfusion pressure, or why we are very concerned about the intracranial pressure? It is given by the equation cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. Okay, the cerebral perfusion pressure should be maintained a minimum of 70. Hence, you should maintain a minimum of 90 millimeters of mercury of mean arterial pressure, and the intracranial pressure should be kept at a minimum of less than 20 or 22 millimeters of mercury in patients with trauma. It is based on the principle of Monroe-Kelly doctrine, because our brain is in the place of a rigid cranial wall. So inside the rigid cranial wall, you have the vessels, you have the CSF, and you have the brain. Whenever there is another important thing that can occupy the rigid cranial wall, for example, in the case of a trauma with a hematoma, or in case of a tumor, this is a space occupying lesion inside the brain, that will displace the either CSF as well as the vessels first. When it reaches the point of decompensation, the brain will start herniating. Once the brain starts herniating, there is already much damage has happened. There is no chances for salvage. That's why whenever you are monitoring a patient with a hematoma, you have to maintain the cerebral perfusion pressure, because the brain can withstand hypoxia for a maximum of 4 to 5 minutes. Maintaining the cerebral perfusion pressure of more than 70 millimeters of mercury is very, very essential to have a better neurological outcome in patients with head trauma. This is an important point. I would like to stress it here. And there is another option for draining the CSF, that is called the endoscopic third ventriculostomy. Endoscopic third ventriculostomy is particularly useful in patients with aqueduct stenosis, cerebral aqueduct stenosis. What is this aqueduct of Sylvius? This aqueduct is the area that connects the third ventricle to the fourth ventricle. Whenever there is any obstruction at the level of aqueduct by any midbrain tumor, patient will have hydrocephalus. In such situation, no need to place the VP shunt. You can even place a third ventriculostomy. You can directly bypass the drainage of the CSF from the third ventricle into the subarachnoid space here. So this is the third ventricle area. This is the CSF area. You can directly make a hole between the third ventricle to the CSF. This is called endoscopic third ventriculostomy. The most important complication that can occur with the endoscopic third ventriculostomy is a basilar vessel that is very close to the area of fenestration that can go in for a basilar artery rupture that can rapidly form a subarachnoid hemorrhage and have a poor outcome. This should be kept in mind while doing an endoscopic third ventriculostomy. It is given by the short form, that is ETV. ETV is commonly done in patients with midbrain tumors or Pons tumors or with patients with cerebral aqueduct stenosis, right? So with this, we have completed this question. Let's move on to the next question. This question is based on the staging of oral cavity cancers and how to interpret the pathological report. A 35 male presenting with a pathological report of wide excision glossectomy with elective neck dissection for a right lateral tongue cancer. We will discuss about what is elective neck dissection later on in the future questions. And the gross findings include an 18 millimeter cross 12 millimeter cross 8 millimeter, or in centimeters, if you put 1.8 cross 1.2 cross 0.8 centimeter tumor with anterior margin 7 millimeter, superior and inferior margin are around 2 centimeters, and posterior margin is 11 millimeter, and medial margin is 5 millimeters. Only if you have oriented the proper tongue specimen, if you see it, you can understand this. But for exam purposes, you should know about what is positive margin, what is close margin, what is negative margin. And 16 nodes gross from the neck dissection specimen. Upon microscopically, the tumor is well differentiated. Whenever there is a well differentiated, it is called grade 1 tumor. Moderately differentiated is grade 2 tumor, and poorly differentiated is grade 3 tumor. It is an invasive tumor, squamous cell cancer histology, and the depth of invasion is 5 millimeters. And no worst pattern of invasion. This is the recent prognostic factor that has been introduced in the recent AJCC staging. All these have been updated in your recent Bailey. Okay, and no lymphovascular invasion and no perineural invasion. These are the adverse effects which you should be worried of while reading the reports. So while reading the reports, you should note the histology, you should note the grade, you should note the margins, you should note the nodal positivity, you should know the depth of invasion, you should know the worst pattern of invasion, you should note lymphovascular invasion and perineural invasion by the tumor cells. All these will be reported in the pathology according to the protocol to decide on the adjuvant management. Okay, so based on this, the pathological staging is. So for this, you should know about the AJCC staging, right? So the recent AJCC staging mentions T1 lesions. T1 lesions up to 2 centimeter. And T2 lesions 2 to 4 centimeters. And T3 lesions more than 4 centimeter. And T4 lesions, they invade the adjacent organs. It can be classified into A as well as B. T4B is usually unresectable. Unresectable means it involves the masticator space, it involves the carotid vessel, or it involves the infratemporal fossa. These are unresectable, like prevertebral fascia involvement, carotid involvement, infratemporal fossa, or masticator space involvement, depends on the tumor location. So T4B are usually unresectable. And they included the important thing that with the T stage, that is the depth of invasion. Up to 2 centimeter when the depth of invasion is less than 5 mm. 2 to 4 centimeter when the depth of invasion is 5 to 10 mm. When the depth of invasion is more than 10 mm. This is T3. So there are different permutation and combination between the depth of invasion as well as the T stage to properly characterize the staging. You can read it in the recent AJCC staging. So what is this depth of invasion that has been recently added in the AJCC staging? So if you look at the tumor, so this is the depth of invasion. This is an ulcerative tumor. Okay, the image 1 shows an ulcerative tumor. So the depth of invasion is measured from the adjacent basement membrane, to the maximum depth of involvement. This is called the depth of invasion. Whereas the tumor thickness, if you take the tumor thickness, you will measure the tumor thickness from here to here. This is tumor thickness. So you should not confuse depth of invasion with the tumor thickness. Here, if you take the tumor thickness, this is the tumor thickness. But what we are more concerned is the depth of invasion, because only more the depth it involves, more the chance for nodal metastasis, and more the chance for lymphovascular invasion, or the more the chance for perineural invasion. This is a proliferating tumor. If you take the tumor thickness, here the tumor thickness will be high, here the tumor thickness will be low. So it will be misleading by calculating the prognosis of the patient. So thereby they recently included depth of invasion as an important prognostic factor. So if you look at this proliferating tumor, this is the actual depth of invasion. Okay, it helps in arriving at the prognosis. Then with regard to the margins, surgical margins. Okay, when it is less than 1 mm or less than or equal to 1 mm, it is called a positive margin. That means the closest tumor to the surgical cut margin is called the surgical margin. Okay, so distance from the surgical cut margin to the nearest tumor extent, this is called surgical margins. When it is up to 1 mm, it is considered positive. 1.1 to 4.9 mm, it is considered close margin. When it is 5 mm or more, it is negative margin. So as surgeons, we aim for our aim is to give 1 centimeter margins all around. That means 1 centimeter 3-dimensional margin: anterior, posterior, medial, lateral, superior, inferior, 3-dimensional 1 centimeter margin. Because once you give 1 centimeter margin, you put the specimen in the formalin along with the primary contraction and the formalin related contraction, there will be 30% shrinkage in the margins. Thereby, only if you give 1 centimeter margin, you can achieve a 5 millimeter margin, so that your margin will be negative. Okay. So with this idea, you answer this question. So this patient has the narrowest margin is 5 mm, that is a negative margin. Narrowest margin is 5 mm, that is a negative margin. And whether it is a T1 or a T2 tumor, that you should identify. The depth of invasion is 5 mm and the size is less than 2 centimeter. Less than 2 centimeter and the depth of invasion is 5 mm. So it comes under T1 category. And the number of nodes, all nodes, 16 nodes are and all nodes are negative. Okay, the nodes are negative. So the final answer is a T1 N0 and a negative margin. It is not T2 since the depth of invasion is only 5 and the size is less than 2 centimeter. And the margin is not closed because the narrowest margin is 5 mm. That means it is a negative margin. If it is 4.9 mm, it is considered a closed margin. Okay. Right. So this is the surgical bed picture which I have done last month. So identify the type of left neck dissection done based on the post-resection bed image shown below. So for this, you should know about the classification of neck dissection and what are the structures that will be removed along with the neck dissection. What are the structures that will be preserved with the neck dissection. For that, you should know about the levels, nodal station levels first. Then we'll move on to this answer. So this is the neck has levels 1 to 5. 1 to 5 for mainly oral cavity cancers, and level 6 is central compartment, and level 7 is superior mediastinal compartment. Superior mediastinal nodes. Level 1 is subdivided into two, 1A and 1B. 1A is submental nodes and 1B is submandibular nodes. So in this diagram, the submental nodes are between the two antibiliar digastric and the hyoid bone. The submandibular nodes between the anterior and the posterior belly of digastric and the angle of mandible, that is submandibular nodes. And level 2 is nothing but from the base of skull to the level of hyoid, imaginary line to the level of hyoid. Nodes along IJV from base of skull to hyoid. This is level 2. Level 3 is from the base of skull of hyoid to the cricoid cartilage is station 3. Nodes along IJV from hyoid to cricoid. And station 4 is, or level 4 is from cricoid to clavicle. These are the nodes along IJV. And station 5 is given by the triangle bounded by the lateral border of sternocleidomastoid, trapezius, and the clavicle. Sternomastoid, trapezius, and clavicle. It is divided into A and B by the cricoid line. Imaginary horizontal line drawn at the level of the cricoid cartilage. Okay. And the station 2 is subdivided into A and B by spinal axillary nerve. So this is the spinal axillary nerve. Nodes that are beneath the spinal axillary nerve are called 2B, or nodes that are cranial to spinal axillary nerve are 2B. Nodes that are caudal to spinal axillary nerve are 2A. And the central compartmental nodes are nothing but this is the neck, manubrium sterni, trachea, thyroid, etc. These are the carotid vessels. This is the hyoid bone. This is the suprasternal space. Between carotid sheaths and superiorly hyoid, inferiorly to the sternum. This area is called level 6. Beneath the sternum to the arch of aorta, this is called level 7. or superior mediastinal nodes. So in thyroid cancers, we will be doing a level 6 clearance and a part of a level 7 clearance commonly, because they commonly metastasize to station 6 as well as station 7. The lateral neck node involvement is quite rare with thyroid cartilage, but when they are involved, you have to remove stations 2 to 5 and not 1, because the metastasis to station 1 is very, very rare, in less than 0.5%. Now, classification of neck dissection. There are several names for classification of neck dissection. It's given by the academic classification. There's the recent one. Okay, this academic classification, and the older one is called the Medina classification. Nowadays, we are not using the Medina's classification. Both are same almost. Okay. This academic classification broadly divides the neck dissection into two types. One is comprehensive neck dissection. And another one is selective neck dissection. In the comprehensive neck dissection, you have radical neck dissection. That means you remove levels 1 to 5 along with omohyoid, submandibular gland, IJV, spinal axillary nerve, and sternocleidomastoid. This is radical neck dissection. Then you have a modified radical neck dissection. This radical neck dissection is given by the name Kreil's neck dissection or Kreil's dissection. This modified is given by the name Boca. He is the one who devised the modified neck dissection. The modified neck dissection, you remove levels 1 to 5, but you preserve any one of the three most important non-lymphatic structures. MRND type 1, you preserve only spinal axillary nerve. MRND type 2, you preserve spinal axillary nerve plus IJV. It's quite varies between any books, between the books. In some book, it mentions sternocleidomastoid. It's better. Nowadays, they are advising to MRND, and you have to write it in the parenthesis like preservation of spinal axillary and IJV, not based on the types. But for exam purpose, this is the right one. Type 3 is you preserve spinal axillary nerve plus IJV plus sternocleidomastoid. This is MRD type 3. And the third one is extended radical neck dissection. It's nothing but radical neck dissection plus removal of other structures. If you remove a part of carotid vessels, or you remove hypoglossal nerve, or remove the neck skin, these are called extended radical neck dissection, or you remove parotid, these are called extended radical neck dissection. Now moving on to selective neck dissection. Selective neck dissection is you remove levels, specific levels 1 to 3. It is called supra-omohyoid neck dissection. You remove levels 2 to 5. This is called posterolateral neck dissection. Or you remove level 6. This is central compartmental neck dissection that is commonly done for thyroid cancer. These are called selective neck dissections. So nowadays we are moving towards selective neck dissection to prevent the complications related to the radical neck dissection, because radical neck dissection will have severe shoulder morbidity to the patient because of the removal of the spinal axillary nerve. It can the patient will have a drooping shoulder and severe shoulder morbidity as well as pain, and there will be flap necrosis as well as neck contractions are more common with radical neck dissection. Nowadays, even in post radiotherapy setting, people are moving towards selective neck dissections. Okay. So now we have identified, we know about the comprehensive neck dissection as well as the selective neck dissection. What do you mean by elective neck dissection? What do you mean by elective neck dissection? Elective neck dissection is neck dissection done when there are no clinically significant nodes. There are no clinically significant nodes. It is called elective neck dissection. Like particularly in the patient, in the previous patient who do not have any clinically significant node preoperatively, yet we have to do a neck dissection, that is called a elective neck dissection. Supposing a patient have a tongue cancer for which you are doing a wide local excision, and you have to do a elective neck dissection by removing the levels 1, 2 and 3 and also 4, because only in tongue cancers you have to remove the level 4, because the chance of skip metastasis to the level 4 is seen in 16%. In tongue alone, you have to remove up to level 4 because of risk of skip metastasis in 16% to the level 4 nodes. Whereas for buccal mucosal cancers, floor of mouth cancers and other areas, you can go out with the level 1 to 3, that is supraomoid neck dissection alone. So now you answer this. So this image shows, I will highlight the important structures. So this is a anterior belly of digastric. This is the posterior belly of digastric. This is the intermediate tendon. Okay. Look at these fibers. This is the mylohyoid muscle. This is the marginal mandibular nerve. It's not clearly visible here. This is the location where this is the location where submandibular gland will be there. Okay. So this is the hypoglossal nerve. This is the carotid. This is IJV. Hypoglossal nerve crosses anterior to the carotid to enter into the tongue. So this is the course of the hypoglossal nerve. Okay, and this is the spinal axillary nerve that is innervating the trapezius muscle. Okay, so here in this image, spinal axillary nerve is preserved, IJV is preserved. So what type it should be? All lymphatic structures have been removed. This is where the sternomastoid would have been there. The sternomastoid has been excised. So 2 structures have been preserved. So it is called modified neck dissection type 2. Okay. I hope you understand the neck dissection as well as the anatomical structures. So these are the strap muscles. Anatomical orientation is a bit difficult for you at this age, but carotid, IJV and spinal axillary nerve you should be familiar with, right? So this is the IJV, this is the spinal axillary nerve. Okay. Right. Moving on to the next question. 55-year-old male underwent primary right composite resection. Composite resection means you are doing removing multiple tissues. Full thickness buccal mucosal resection with segmental mandibulectomy with right modified neck dissection and microvascular free fibular flap reconstruction for a buccal mucosal tumor near the mandibular alveolus. His pathological report shows maximal tumor size of 4.6 centimeter. So the tumor size is more than 4 centimeter. It easily becomes T3. And the closest margin is posterior, which is 4 mm. That means margin is close here. Margin less than 5 mm is close. Lymphovascular invasion is there. Perineural invasion is there. These are the risk factors which have an increased risk of recurrence. And the depth of invasion is 1.6 mm. So when the depth of invasion is more than 10 mm, with the size more than 4 centimeter, it becomes T4. And 4 out of 22 nodes are positive, with the largest node, that is 2.2 centimeter, with extranodal extension. What is the appropriate adjuvant therapy indicated? So we have read about the T staging. In this question, we will read about the nodal staging first, then we'll go in for indication for adjuvant treatment after oral cavity cancer surgeries. So we know the margins, right? So margins less than or equal to 1 mm is positive. 1.1 to 4.9 is close. 5 mm or more is negative. This is regarding margin. With regard to the nodal staging, so N1 is single node, that is less than 3 centimeter. N2 has 3 divisions: N2A, N2B, and N2C. N2A is single node more than 3 centimeter but less than 6 centimeter. N2B is ipsilateral multiple nodes, all less than 6 centimeter. N2C is bilateral or contralateral node, all less than 6 centimeter. N3 has 2 divisions: N3A, single node or any node more than 6 centimeter, single or any node more than 6 centimeter. N3B is any node of any size but extranodal extension is seen. That means microscopically, when there is tumor growth outside the node, the tumor enters the lymph node through the lymphatic channel. Inside the lymphatic channel, initially it forms a metastatic deposit. Later, it grows out of the capsule of the node, that is called extranodal extension. That is N3B. Right? So with this, we will answer this question. So the maximal tumor size more than 4 centimeter, depth of invasion is more than 10 mm, more than 4 centimeter, more than 10 mm is T4. Margin and next nodal staging, 4 out of 22 nodes. So 4 out of 22 nodes, with largest node is 2.2 centimeter with extranodal extension. That is more than 1 node positive is N2, but extranodal extension means it becomes N3B. Okay, PT4, you have to write as P, that is pathological. If you achieved a clinical diagnosis, it becomes C. And the margin is close because it is 4 mm. What is the appropriate adjuvant therapy indicated? So there are 2 important adjuvant therapies that are used for head and neck, oral cavity squamous cell cancers. Number 1 is radiotherapy alone. Number 2 is chemoradiotherapy. Radiotherapy alone, RT alone, is indicated when the risk of recurrence is more than 20%. That is particularly seen in patients with T3 or T4 tumor, N2 or above. Nodal metastasis is there, T3, T4 disease. Primary is larger, bulky, node positivity is there, indication for RT. And margin close or positive margin. And other risk factors: lymphovascular invasion positive, perineural invasion positive, Okay, so these are the indications for post-operative RT as well as extranodal extension. Okay, so this is the indication for adjuvant RT. Chemo RT is indicated in only 2 situations, that is given by 2 important randomized control trials. Concurrent chemo RT. Concurrent means you give chemo during radiotherapy. Number 1, whenever there is extranodal extension, and number 2, positive margin. This patient has extranodal extension, so hence this patient should receive adjuvant concurrent chemo radiotherapy and not radiotherapy alone, right? So there is evidence for this adjuvant chemoradiotherapy. Okay, so adjuvant chemo RT is given by the evidence 2 trials, EORTC 22935 trial and as well as RTOG trials. In both trials, they found disease-free survival benefit as well as OS benefit. Is just for your additional information in extranodal extension as well as positive margins. But you should know how and what is concurrent. Okay, so concurrent is here the chemo is used as a radiosensitizer. So what is the dose of radiotherapy that is given in an adjuvant setting? So adjuvant setting, it's usually given as a 50 gray. This is the total dose, 1.8 gray per fraction. So totally it comes around 50.4 gray in 28 fractions. Fractions is each segment or each dose of radiation delivery, it is called a fraction. Per day, it is given 1.8 gray for a total of 28 days, thereby leading to a total dose of 50.4 gray. Ideally, radiotherapy will be given in 5 days a week, Monday to Friday and Saturday, Sunday break, to allow the normal tissues to regenerate due to the radiotherapy induced injuries. Chemotherapy, usually the commonly used chemotherapy is a cisplatin. It is used as a radiosensitizer. It is given weekly. It is given for 6 cycles. So weekly cisplatin, every week on Monday you will be receiving cisplatin, and Monday to Friday you will be receiving 5 fractions, 2 days rest, again Monday chemotherapy followed by radiation. Here the dose of chemotherapy is not that much higher, it's a minimal dose. It acts as a radiosensitizer to increase the efficiency of radiotherapy to prevent the recurrence. Right. Now moving on to the next question. Identify the anatomical structure arrow marked yellow in post left parotidectomy bed. So this is the cranial end that was mentioned here. So this is the ear lobe that has been retracted. Okay, so this is the post parotidectomy bed. So if you trace, this is the main trunk of the facial nerve that divides into zygomatico-temporal branch as well as the cervical branch. This zygomatico-temporal branch, zygomatic, they have 2 branches. Then this is the buccal branch. It also goes as a 2 branches. And you have a marginal mandibular branch and you have a cervical branch. So this is the facial nerve branches. Just beneath the facial nerve, so the parotid will be encasing the faciovenous plane of Patty, that you know, right? So what is faciovenous plane of Patty? So this is the parotid gland. The parotid gland will be situated like this. This is the deeper lobe. Here, vessels will be there. This will be the superficial lobe. So it will be enclosing the fasciovenous plane of Patty. The fasciovenous plane of Patty structure importantly includes from anterior to posterior. Number one is the facial nerve. So anterior to posteriorly, first facial nerve, second retromandibular vein, and immediately deeper to it is the external carotid artery. So in this picture you show this is the external carotid artery. This is the retromandibular vein. This retromandibular vein divides into an anterior branch as well as a posterior branch. The posterior branch joins with the posterior auricular vein, post-auricular vein, to form the EJV. The anterior branch joins the common facial vein, joins the facial vein to form the common facial vein. This is the normal anatomical scenarios. See, here it is clearly evident. This is the facial vein that joins the anterior branch. Okay, this forms the common facial vein. This is the anterior branch of retromandibular vein. This is the posterior branch of the retromandibular vein. This is the posterior auricular vein. This forms the EJV. This forms the common facial vein. This is the retromandibular vein. So based on this question, so this is the bluish structure, that is the vein. So the answer is a retromandibular vein. It cannot be facial artery because facial artery is seen along the angle of the mandible here. This is where the facial artery, if you can press it against the angle of mandible, you can even look for your facial artery pulsation. Just anterior to the masseter muscle, if you palpate it, you can palpate the facial artery. Okay. So facial artery is not a possibility. The bluish structure is the retromandibular vein. And another important things or questions can be asked from the parotidectomy surgeries are, what are the common complications of parotidectomy surgeries? It is given by 4F. First F is flap necrosis. So to prevent the flap necrosis, nowadays you are using modified Blair incision. And the next F is given by fistula, that is parotid fistula. If you fail to ligate the parotid duct, you can develop a parotid duct fistula. And the third one is the facial nerve paresis or a palsy. And the final one is going to be Fraze syndrome. We will discuss about Fraze syndrome in the next question. What are the important anatomical landmarks that can help you to guide the location of excuse me. Okay. What are the important anatomical structures that guide the location of facial nerve trunk during the surgery? So facial nerve pointers. The commonly used pointers in surgery is, number one is posterior belly of digastric. The facial nerve trunk lies just superior and deep to posterior belly of digastric. Number two, Conley's pointer or tragal pointer. So the facial nerve trunk lies anterior and inferior, lies 1 centimeter anterior and inferior to the pointer. The final thing is posterior auricular artery. facial nerve lies just beneath the artery. That's why any bleed that happens near the facial nerve trunk region, anticipated facial nerve trunk region, you should be very meticulous and careful in applying the electrocautery. If you use too much of electrocautery without identifying the bleed, you might end up with transecting or even badly injured facial nerve. So what if the facial nerve is preserved? It is called conservative parotidectomy, right? What if the facial nerve, can the deep lobe be removed by preserving the facial nerve? Yes, that is possible, but a minimal amount of parotid tissue will be left behind. That is called total conservative parotidectomy. What do you mean by radical parotidectomy? So conservative parotidectomies are nothing but preserving facial nerve. Radical parotidectomy is removal of facial nerve due to tumor involvement, not due to poor skill. Only due to tumor involvement, you have to remove the facial nerve. And the amount of facial nerve trunk that has been removed can be reconstructed with a cable nerve graft, or the commonly used nerve grafts are greater auricular nerve as well as the sural nerve. Okay, so facial nerve reconstructed with greater auricular nerve or sural nerve. This is called, this type of nerve grafting is called cable nerve graft. So these are the questions that are very much high yield with related to the parotid surgeries. And there is a recent surgery called extracapsular parotidectomy or an adequate parotidectomy that we will discuss in this question. All of the following are used to prevent the Fraze syndrome except. So what do you mean by Fraze syndrome? Fraze syndrome is nothing but gustatory sweating. You all know the parotid glands, any salivary gland that requires, that gets the secretory fibers from the parasympathetic system. So all secretory functions will be promoted by the parasympathetic system. So it is from the inferior salivatory nucleus. The parasympathetic fibers relay in the otic ganglion. From the otic ganglion, the parasympathetic fibers travel through the auriculotemporal nerve and innervate the parotid. So during the parotidectomy, the auriculotemporal nerve fibers that is innervating the parotid will be injured. And once the parotidectomy has been completed, this auriculotemporal nerve, the injured auriculotemporal nerve, will start regenerating through normal nerve regenerating mechanism and starts innervating the sweat glands that are already innervated by the sympathetic nervous system. So this injured auriculotemporal nerve, they regenerates and cross innervate the sweat glands of the skin overlying the parotid. Hence, whenever the patient starts eating, there will be secretory fibers that will be passed through the auriculotemporal nerve and it will stimulate the sweat glands, thereby causing sweating as well as erythema. Local erythema is due to the local vasodilatory effect of the sympathetic nervous system. So that causes, eating causes erythema as well as sweating. Why this Fraze syndrome occurs? Because of the thinner skin flap. If you raise a thicker skin flap, so what are the methods to prevent the Fraze syndrome? If you raise a thicker skin flap, the chances of auriculotemporal nerve innervating the sweat glands is very less. Number 2 is you incorporate the SMAS, that is superficial muscle aponeurotic system, between the parotid bed and the skin. Or you place some temporalis flap, temporalis bulk. Generally, this patient will have a cosmetic deformity. There will be a hollow just behind the mandible and the preauricular region because the parotid gland is removed. To obviate that cosmetic defect, temporalis flap muscle will be filled in the area. That also found to prevent the Frey syndrome. The treatment of Frey syndrome is number 1, first line is by Botox injection and antiperspirants like aluminum chloride. This is the treatment of Frey syndrome. So with this, can you answer this question? Which is used to prevent Frey syndrome except? So thicker skin flap is used to prevent, temporalis flap is used to prevent, SMAS cover is used to prevent, whereas aluminum chloride is used to treat and not prevent the Frey syndrome. So this is the answer. Right. Now we will discuss about skin malignancy a bit. 40 male presented with a 2 centimeter black pigmented ulcerated lesion in the back with ABCD signs of melanoma. What is the next step in the line of management? So, how to deal a patient with a suspicious melanotic lesion? So, this patient has a black pigmented ulcerated lesion. The first differential diagnosis, we will think it as a melanoma, and it has been very well proven or more suggestive by ABCD signs. What do you mean by the ABCD signs of melanoma? A for asymmetry, B, borders are irregular, C, color variegated, that means the color gets variation. There is variation during the, and finally is diameter, that is more than 6 mm. Any mole or any black lesion more than 6 mm, you have to very well think in terms of melanoma. And E is evolution over time. Initially, it might be 4 mm, later it has become 8 mm. Initially, the color is brown, now it has darkly pigmented. Evolution over time. When these are suspected, the lesion is more likely to be a melanoma. So what to do when you have a suspicious diagnosis of a melanoma? When the lesion is very large, first you should locate the size and site of the lesion, and you should palpate for any regional nodes. There are obvious bulky nodes, that means it is more likely to be a skin melanoma rather than a non-melanotic lesion. So when the size is up to 2 centimeter, you can very well go out with a excision biopsy. When the size is more than 2 centimeter, you have to go take for an incision biopsy or a punch biopsy. Why not punch biopsy or any other biopsy for a smaller lesion? Because we have to prognosticate or risk the lesion by measuring the Breslow's thickness. That Breslow's thickness is possible only if you take an excision biopsy. Ideal recommendation for smaller lesions: excision biopsy with narrow skin margins. This is given in the book. So the best answer will be excision biopsy with a 2 mm margin. So how to move about the management? For the question is over, the answer is over. Let's discuss about the management of melanoma. So for smaller lesions, that means you have done an excision biopsy. Now you are measuring the Breslow thickness. So Breslow thickness is similar to the depth of invasion. But the depth of invasion is calculated from the adjacent basement membrane. Likewise, the Breslow thickness is calculated from the adjacent basement membrane to the maximum depth inside the dermis. Based on the Breslow thickness, the melanomas for treatment aspect are classified into three manners. One is thin melanomas, another one is intermediate thickness melanomas, and finally thick melanomas. We will read as it will help in the treatment guiding. The thin melanomas are melanomas with Breslow thickness less than or equal to 1 millimeter. Intermediate melanomas are more than 1 millimeter to 4 millimeters. Thick melanomas are more than 4 millimeters Breslow thickness. Right? Why this Breslow thickness is very important? Because melanoma is an aggressive tumor. So any melanoma that has gone beyond the depth of 1 millimeter, it has a higher chance for nodal metastasis. So regional nodal staging should be done in patients apart from thin melanomas. And it also helps in guiding the surgical margins for excision. So why to identify why Breslow thickness is important? Number one, guide surgical margin. Number two, guide nodal metastasis risk. Risk assess the nodal metastasis. So for Breslow thickness less than 1 mm or up to 1 mm, wide local excision with 1 centimeter margin is recommended. For anything more than 1 mm, 2 centimeter margins are enough. This has been brought about by 4 important RCTs that compared the thickness of the melanoma along with the margins, and they have found this is the final inference. Up to 1 millimeters, 1 centimeter margin is enough. More than 1 millimeter, 2 centimeter margin is enough. What is the margin recommendation for melanoma in situ? That is 0.5 centimeter margin is enough. So in this patient, when you have a Breslow thickness, you have to again go ahead and do a wide local excision from the surgical cut margin that has been already done. And before doing that, whether